So my title is Managing the Anticoagulated Endoscopy Patient, Guidelines versus Reality. And it is interesting that you invite somebody from the United States with the political storm we're in about talking about reality. I'm not sure what's reality and what's not anymore. But actually, I'd like to retitle this, Managing the Endoscopy Patient on Antithrombotics. Obviously, anticoagulants don't include antiplatelet agents, so it's really managing the patient on antithrombotics guidelines versus reality. So there are published guidelines, of course, on how to manage patients that are on antithrombotics. There was a guideline from January of 26 published in GI Endoscopy by the ASGE, and there was a guideline also later that year in 2016 published in Endoscopy, which was a joint statement by the British Society of Gastroenterology and the ESGE on management of patients who are on anticoagulants and antiplatelet drugs. So we do certainly have guidelines. We know that. Now I'm gonna give myself a pat on the back. I guess, again, Trump is here. No, but high-risk procedures. So I gave a talk at DDW in 2015. And I talked about what are high-risk procedures and how to manage patients on anticoagulants, antithrombotics, on high-risk procedures. And at that time, I sort of drew a line in the sand. So I had what I thought were the high-risk procedures identified by the ASGE, by the ESGE, and the British Society. But I thought, do I really consider the ones below the line as high risk? Variceal band ligation, is that really a high-risk procedure for bleeding? Luminal stent placement, endoscopic ultrasound, and coagulation of ablation of tumors or vascular lesions. But the rest, I think most people would agree. Now, the reason I put that up is because when I went to put this talk together, I realized that there's yet another set of guidelines, and this was just recently, well, within the last year, year and a half, management of patients on antithrombotic agents, Joint Asian Pacific Association and Asian Pacific Society. And mostly a couple things I wanted to point out. One is there's a nice box where they say, here are the major differences between our guidelines and the other guidelines. And I don't necessarily want everybody to read every part of it, but it does point out that they're trying to say, yes, we have guidelines, but those guidelines actually don't necessarily agree with one another 100%. And they broke it down for non-variceal upper GI bleeding, or obviously emergent procedures, and then they broke it down with elective procedures and actually pointed out the differences amongst the society guidelines. So when you talk about guidelines, then the question is, whose guidelines are you following? And it brings me back a little bit to what's high risk. So ESGE and ASGE agree that these are the high-risk procedures: polypectomy, ERCP with sphincterotomy, ampulectomy, MRESD, dilation of strictures, therapy of varices PEG, EUS, etc. But this more recent paper, which I thought was interesting, looked at it a little bit differently than sort of the way I looked at it, and they defined low risk, high risk, and ultra high risk, right? So the low risk, in fact, they include esophageal, enteral, and colonic stenting, which I actually agree that most uncomplicated enteral stent placement is not a high risk for bleeding. Likewise, argon plasma coagulation is not considered high risk. So that's one difference. The other difference is that they broke in high risk and ultra high risk, which is interesting. And ultra high risk being ESD, EMR of large polyps greater than 2 centimeters. They obviously don't include what do we do about POEM, what do we do about GPOEM, how about Zenker's therapy, and what about some of the newer EUS-guided biliary drainage procedures? Where do they fall in? Are they high risk or ultra high risk? So I think part of the problem with guidelines, and this is sort of where I start, is for our reality, we have cases that may or may not even fit within the guidelines. But I will grant it that most of the things we do certainly probably fall into guidelines. So what about the reality? What do we actually do? Well, part of the problem is we don't have studies that actually say this is what the guidelines say, and then this is what we actually do, right? There's a big gap, and we know that we don't always follow the guidelines. And for example, we see a patient, as Jürgen mentioned, who's on our list, who was scheduled, that's on these medications. They're already there. Their IV is in place. They're expecting a procedure, and what do we do? Do we cancel the procedure? Do we back up? How do we get out of this? Do we just proceed? Or we have a patient that's really what we think is high risk for taking them off the agents. Do we proceed and do the procedure knowing that we have a higher risk of bleeding? And those are the problems with the reality that we work in. So part of the reality I'll break down here is, number one is, what procedures is the individual endoscopist willing to perform with a patient on antithrombotics? So I might be comfortable with performing a certain procedure with a patient on antithrombotics, but yet my colleague next door says, no way, I wouldn't do that procedure, right? So that's also part of the reality, is the individual endoscopist performing this. And then if one does proceed with a procedure on antithrombotics, do we do procedural prophylaxis? In other words, do we do something different during that procedure that we would normally not do to prevent bleeding in that patient? That could be also a reality and not necessarily in guidelines. When to resume anticoagulants is certainly in guidelines, but I'm not sure that we don't follow our own sort of principles based on what is our really perceived risk of bleeding, which again is part of the reality. And how often do we actually use bridging protocols, and which protocol do we use? The other part about guidelines are they're certainly limited due to relative lack of data for endoscopy. So these guidelines are based on weak evidence of experts, which is, I think that you take a grain of salt with that. If you're the expert, you think that it's really good. But antithrombotics agents, the other problem is it's a rapidly evolving field. And so some of these guidelines that were written in 2016 may already be somewhat obsolete, only 3 years old, or maybe obsolete a year later for certain things that have now come out. So our guidelines really relevant on a daily basis. And then the other thing is combinations of antithrombotics and antiplatelet agents are generally not included in guidelines. So they'll tell you if you're on dual or direct oral anticoagulants, or if you're on warfarin, or if you're on a antiplatelet agent, but what if you're on combinations of these? How does that apply in reality? And so we don't know, and our daily practice is going to be different, of course, than what the guidelines are. But what can help us with our real-life decisions when we do these? Well, there's some recent evidence, particularly in colonoscopic polypectomy, to help us perhaps make some of these decisions. And several of these have just recently been published. One of these just published in Clinical Gastroenterology and Hepatology on patients prescribed direct-acting oral anticoagulants and a low risk of polypectomy complications. So this looked at a large national insurance database, and I won't go through all the details of the study, but I wanted to point out that they had 59, almost 600,000 patients in the control group, almost 1,600 in the direct oral anticoagulants, over 3,000 in warfarin, and over 6,000 with clopidogrel. So not small numbers of patients that help us. And basically, what they showed is 30-day complication rates after polypectomy were not significantly different between controls, patients on warfarin, patients on dual agents, and patients on clopidogrel. Likewise, they looked at CVAs, need for admissions, myocardial infarction, et cetera. But I think it's a paper that's worth pointing out, at least in this particular study. Maybe these procedures are not as dangerous as we thought. Now, I'm pretty sure these are not 2 to 3 centimeter polyps we're talking about, right? They're probably the average polypectomy that's performed in practice. But again, they may not be quite as dangerous as we think. Here is also a very recent study in gastroenterology, risk of polypectomy bleeding with uninterrupted clopidogrel therapy in an industry-independent, double-blind, randomized trial. And basically what they showed was, I think I like this box because it really tells you what they're finding, is continuation of clopidogrel was not associated with an increased risk of delayed post-polypectomy bleeding. But again, the limitations were these were not large polyps. They were not complicated polyps. They were relatively small polyps. But again, it helps us because our guidelines right now would say that you shouldn't do this. And I think we're generating some data that maybe the guidelines, or at least give us some evidence that we can act outside of the guidelines and help us refine or revise the guidelines. And then here's another paper, not necessarily, well, not in patients who are on anticoagulants or antithrombotics, but that clip closure prevents bleeding after endoscopic resection of large polyps in a randomized trial. And suffice to say, these were polyps greater than 2 centimeters, and the benefit was seen in patients who had proximal or right-sided colonic polyps larger than 2 centimeters that were resected that had a significant reduction in bleeding, suggesting perhaps that this might be a way of prophylaxing in patients that you consider high risk that might be on antithrombotic agents. Again, we need more studies. And here's a paper of safety of polypectomy for colorectal polyps in patients on antithrombotic medications from outside the United States, published in Digestion. But not a small study. They had over almost 2,500 polyps in over 1,000 patients. They had 549 polyps in patients in the antithrombotic group. And basically, they showed that with cold snare polypectomy, it did not appear there was a significant difference in bleeding using cold snare techniques. So maybe what we can do then is, of course, modify what we do on these patients that come to us that are on these agents. What about the other procedures, EUS and antithrombotic agents? There's 4 studies from Asia. They're retrospective studies that have relatively small numbers of patients. They use variable needle gauges, and they had mixed results with regards to bleeding compared to controls, some higher, some the same. ERCP and antithrombotic agents, there's very, very little published data for ERCP, with one retrospective study showing increased risk with antiplatelet agents, but not when they accounted by multivariate analysis. That was published Gut and Liver in 2018. So again, it comes back to the old philosophy of managing patients on antithrombotic agents. It's always about a balance between risk of bleeding and risk of thrombosis. And I think in a lot of ways, we individualize these patients, whether or not we use guidelines or our own personal practice. But I think, again, the prevention of bleeding we can do and have an impact on our procedural techniques. Certainly in ERCP, we can perform balloon sphincteroplasty rather than sphincterotomy, and I think that's something that I do relatively often in my practice. And of course, the use of nonsteroidals and pancreatic stents have reduced the risk of pancreatitis that is a potential problem with balloon sphincteroplasty. One other thing I do that's not certainly in the guidelines is placement of fully covered self-expandable metal stents in a patient who's at extremely high risk, who needs a sphincterotomy, somebody who's going to go on full anticoagulation almost immediately. There's not data to support this, but in my experience and a few of my other colleagues also do this. It requires another procedure to remove the stent, but may be something useful. We don't know if there's really an effect of hemostatic powders on delayed adverse events or bleeding from ERCP. When it comes to EUS, I think we might be able to use 25 gauge needles rather than use 22 gauge or 19 gauge needles. And certainly we just mentioned on colonoscopic polypectomy, perhaps prophylactic clips in high-risk patients. Certainly, cold snare is gaining a lot of momentum, and I think this is the ideal group of patients that you could use a cold snare technique. And again, we don't know whether or not hemostatic powder really would have any effect on delayed bleeding. There's things that need to be looked at. So in conclusion, certainly an increasing number of patients are receiving antithrombotic agents and require endoscopic procedures. Various published guidelines are available with some disagreement about what constitutes high-risk procedures. There are emerging data to impact real-world resection of colonic polyps while continuing antithrombotic agents, but I think there are inadequate data to guide what we do with EUS ERCP and other non-colonoscopic procedures as far as do we have to follow the guidelines to the letter. And real-world management is dependent on a variety of factors, not the least of which is the endoscopist performing the procedure, and certainly provider preferences in terms of how to manage the antithrombotic agents. Thank you.
So Todd, thank you very much for this fantastic talk. I think lots of topics that could deserve discussion here. Any questions, comments, please?
Yeah, can I ask what would you do today for the patient who is cardiovascular risk, they're on clopidogrel, they need a colonoscopy? Would you advise them to stop their clopidogrel if the cardiologist is happy, or proceed with a plan to clip if you come across a polyp?
So I guess the real question is the indication a screening colonoscopy? So I'm going to assume that the patient's referred for a screening colonoscopy, right? So I think what I would do is I would proceed with the colonoscopy and consent the patient and say, look, if we find small polyps, I'm comfortable taking those out with cold snare. If we find really large polyps, again, I might define a really large polyp bigger than 3 centimeters, then maybe what we'll do is we'll take biopsies, make sure it's not cancer or high-grade dysplasia, understanding that that may make resection later difficult. And then, because that's not going to kill the patient, right? You've identified a polyp and maybe come back on another time for a second endoscopy rather than stop the endoscopy or not do the endoscopy or stop the medication, yeah.
Todd, a few years ago, we had a death in our practice on actually before the patient arrived. The patient had been told to stop both aspirin and clopidogrel 7 days prior to a routine surveillance colonoscopy, and when they didn't show up for their procedure and we called to reschedule, we found out the patient had a fatal myocardial infarction the day before the procedure.
Yeah.
That, to me, is the most common issue that we see now. We see it all the time. The patients are stopping both aspirin. How do we address this issue of the patient who the GP is recommending incorrectly to stop aspirin?
Yeah, that's a great question, and as you know, that's also been published as a complication of stopping the medication. So I don't know how to answer it completely. In our practice, when the patient is called and they tell us what medications they're on, and it includes antithrombotic medications, it comes back to a physician who then has to make the decision along with the reviewing the records and then talking to the provider. And perhaps what needs to be done is a triage sort of program in patients that are on anticoagulants, antiplatelet agents to really stop and say, okay, we're not going to routinely either say stop or routinely tell you to have the procedure, and those people get put off to the side and they have sort of, like I said, a triage. It's going to take person power to do that, but I think that would be the best thing for safety purposes. But I totally understand what you're saying is that's a major problem, yeah.
This is a big problem.
Yeah.
And there's going to be a paper coming out in EIO, I think, the next 6 months. It was from the University of South Carolina group. It was, I think, Joel L. Munzer is on it. And they looked at how many patients like this stopped their antithrombotics before, and then they actually did an intervention where on their communications to the patient, if you're inviting the patient, it actually now says on there, do not stop your aspirin or, I forget the terminology that they use, but they didn't use medical terminology. unless you speak to your gastroenterologist, which is not always easy to do also, but they actually showed a significant drop in patients stopping because the general internists have no clue. They think
Right.
that even to stop their
Yeah.
aspirin, and in patients who are taking secondary prophylaxis, it's incredibly dangerous.
Yeah.
So just in answer to that, and it is person power, we do exactly that. We use the word blood thinners because that kind of incorporates a lot of things. But we have a senior nurse-led pre-assessment service for anyone who is on, who has comorbidities for screening or symptomatic. And that's, so if they're not seen in the clinic by a gastroenterologist first, if they're a direct access patient, they get a telephone call and they are guided through it. I don't think there are shortcuts to it because it's so important. And in the age where we're scoping more people and there's an urgency to bring them in, if you cut corners, then that's where there are problems. So it is person power, as you say.
Yeah.
Actually, I think too often we are dealing with a black box on the other side, right? So the question, can the patient stop? And is the situation, if you postpone the decision, you have him off the day program, but maybe in half a year he's still taking the same med and has to do that. So I think there's a lack of interaction, isn't it?
Yeah.
Hans.
Well, I think it's very important to distinguish between antiplatelet and anticoagulation of the patient. And the problem are those who receive both.
Right.
So after an immediate cardiac event, they have an antiplatelet, sometimes double antiplatelet therapy and an anticoagulation. Right. So you have a situation then, and you have to maybe some bleeding or some polyp which is bleeding, and how to deal with that. I think in your case, it's a question of was it right to stop the medication? It was not right for endoscopy part, but was it right on the cardiology part? I think that's the major problem, is what are we dealing with, and is it possible to stop it? Nobody does bridging in Germany anymore for anticoagulation, at least not for Marcomar therapy or warfarin therapy, but I think we have to see the one side. What's the indication for the blood thinning therapy? It's a good expression. And is the combination he's receiving correct? At least in the German and European guidelines, aspirin is never stopped, at least not in our recommendation. So this is a very clear message to the GPs: never stop aspirin before any procedure.
They also don't realize that aspirin for us isn't really a problem. I mean, right?
I think one major issue would be also the higher the risk, the more you should think about your indication. And sometimes it's a reflex. You know, you see a polyp, get rid of it. And I think, you know, that is something that you might regret later. So rethink your indication. But
in the big picture, a polyp is probably the least of their problems, right? In terms of, you know, a 10 millimeter polyp's not going to kill them, but their heart, et cetera, that they're dealing with is the bigger issue. Yeah.